Um, Please contact our team if you have any technical issues. So as a courtesy to others, we ask that you remain on mute when you're not speaking to reduce the background noise. We may mute you if there's a lot of background noise, but you can always unmute yourself using the small button at the bottom of your phone that looks like a microphone. The meeting facilitator is going to sequence the speakers and may also call on people to speak to ensure we have a range of perspectives. And you can raise your hand by clicking the button under reactions at the bottom of your screen, or you can enter questions into the chat box. So before we begin the meeting today, I'd like to recognize the council members who are attending. And I'm going to start off by reading off the kind of longstanding members. We do have 4 new members today, and I'm going to just ask them if they'd like to do a brief introduction when we get to their names. So let's see. I was going to hold them to the end, but maybe the easiest way to do this is just as I kind of go down this list. So one of our new members today is Carlene James. Carlene, would you like to introduce yourself?
Are you all hearing me? Good evening.
Good evening.
Okay, great. Hi, I'm Carlene James. I wasn't sure. I couldn't find the mute button, so I wasn't sure if you were hearing me.
Thank you. Welcome. Good afternoon.
Good afternoon.
So we obviously have the executive director, Ben Steffen. We have our co-chairs, David Sharp and Dr. Reedman. We have John Leese, who is also another new member. John, would you like to introduce yourself?
Sure. Hi, I'm John Leese. I'm the practice administrator for Calvert Internal Medicine. Calvert Internal Medicine is a multi-specialty internal medicine group in Southern Maryland. Thank you.
Thank you. We have Krista Spiker from HSCRC. Krista, I know you're kind of new to this. If you just want to say briefly what your role is at HSCRC.
Yeah, sure. Hi, everyone. I'm Krista Spiker. I'm from the HSCRC. I'm the representative for HSCRC for this council. I just started in December at HSCRC, and prior to that, I was at CMS and CMMI and worked on the Maryland model for a while, and came from Maryland Medicaid many, many years ago. So very happy to be here and work with all of you. So thank you.
Welcome.
Thank you, Krista.
Sorry again for improper introduction for myself. So I don't mind introducing myself properly once you're done with the other introduction.
Go ahead. Go ahead, Carlene. Go ahead.
Okay, I'm sorry. I'm Carlene James. I'm a licensed social worker, and I work with Southern Maryland Medical Group. We're a private medical practice located in our Greenbelt and Camp Springs and Riverdale locations. I'm the program manager for our MDPCP program here, and have been a social worker for about 26 years, doing primarily case management and managing case management programs. So I'm very familiar to working in the medical field as a medical social worker, and happy to be a part of this advisory council.
Great, thank you so much. So we have Alan Field on the phone. We have Chad Perman. We have Claudia Cicchetti, who is also another new member. Claudia, would you like to introduce yourself?
Sure. Good evening. My name is Claudia Cicchetti. I'm with Annapolis Internal Medicine. I've been with them for 15 years. I'm the quality care coordinator, and I am the lead person with the Maryland Primary Care Program as well, as far as the reporting and all goes.
Thank you so much. Welcome. So we have Debbie Kuchka-Craig. We have Jean Ransom. We have Dr. Trumbull. We have Kathleen Logren. We have Dr. Bazinski. We have Kevin Hayes. We have Laura Goodman, who is sitting in for Tricia Brody. We have Laura Russell. We have Michael Barr, Dr. Okeke, Dr. Berenson, Dr. Berkowitz, Scott Rose. See if I've missed anybody. I think those are all the council members. Are there any council members that are present that I didn't mention? We do have another new member, Nora Hoban, who I think is joining as we speak. Nora, can you hear us? She's on. Okay, I think that's at this time I will turn it over to David Sharp to start with our opening remarks.
Hey, good afternoon, everyone. Just to be brief, to not take too much time, but welcome. We're excited to have this meeting with everyone. It is our first meeting in quite some time. And we're looking forward to gathering your thoughts on the important policy questions that are included on the agenda. With that, I would invite our Executive Director, Mr. Stefan, to make some comments.
Yes, David, I'm not going to have any comments right at the moment. I want to thank everyone for attending. I heard Dr. Reedman's admonition to let's get down to business. So I'll pass it back to you quickly. And hopefully I don't hear too much from him after the meeting about hogging the meeting agenda, but go ahead.
Thank you very much. So let's make progress through the agenda. Our first up is Chad Perman. Chad is going to give us a brief update on the work of the MDPCP to help bring everyone up to speed since last we met.
David, before we start with that, I just want to make a brief comment on Chad's presentation. We have a lot on the agenda, and so I'll preface Chad's initial update with the point that if we'd like to get through that at a fairly rapid pace. We don't want to cut anybody off, but if we do cut you off and we're running a little long on comments on Chad's initial presentation, it's nothing personal, but we really want to get to the agenda items and the policy items and spend some time on that. So again, I don't want to cut Chad off by any means, but we want to get to sort of the meat of the committee meeting. So I'll let Chad take it from there.
Well, thanks, Dr. Reedman, and thanks, David. Nice to see everybody. It's been a while, and lots happened since we last met. I think it's been over a year. Just a housekeeping item real quick, Dr. Reedman and David, how do you want to handle questions? Are we going to do questions at the end of each section? And or through chat?
I think I would do it the way we've been. I think if you can hold your questions, fine, but also if they're pertinent during your presentation, I think that's fine.
Okay, great. So then I'll get started, and David and Melanie and Dr. Reedman, I'll just look to you to interrupt if there's comments coming through that you want me to address.
Yeah, sorry, just 1 second, Chad. I'm having a little technical difficulty. Just 1 second.
Okay, no problem.
All right, well, that was enough from Chad. Let's move on to the
Done with me already.
Yeah.
Yeah, so for today, while Melanie's getting the slides ready, I'm gonna do a brief update on what's happened in the last year in the program, make sure we're kind of on the same page in terms of some of the updates. And then we'll go into 3 policy items that we want to get some feedback and input from all of you on the council. And I know we have some other folks who are on the line as well, including some of my staff who are on the line to answer questions, provide some color if necessary. So with that, let's go to the next slide. Great. And then, okay. So want to call out what's happened in the last year just in terms of accomplishments for the program. And sorry, I'm seeing, there we go. Okay. So a quick update on some of the things that happened since 23 in the program. We've had a new year start on the program for 24. So since then, we've onboarded 25 new participant practices, including one FQHC, as well as a new CTO for the 2024 program year. We've also seen some significant improvements and milestones around behavioral health integration. We have practices report on screening for brief intervention and referral for treatment as part of the ESPER process for substance use. The program has reached 1 million MDPCP beneficiaries have been now screened, so quite a milestone. And we have 338 practices that are currently in the program that are doing ESPER. In terms of health equity, we've worked a fair amount with 211 Maryland to help update their resource directory to make it more robust and then make it accessible back to practices, not only through the 211 website, but also making it now available through CRISP. We also help 211 develop some partnerships in Eastern and Western Maryland to make those resources more robust. As you guys know, we offer a learning system, education and quality improvement for practices. So we have annually hosted in partnership with Care First, an advanced primary care staff training academy. And that one has had significant participation. I think this last year we had over 200 staff from primary care practices around the state that participated in that. We've also continued to develop new tools for the program, particularly through CRISP. So we built with CRISP a pre-diabetes and a non-fatal overdose smart alert that practices can subscribe to and get if their patients have one of those. We've also developed some new tools and information. So there's a dashboard specifically to track expert and provide feedback back to practices. Separately, we have worked with Medicaid and built a multi-payer reporting platform that just went out in the end of the fall and is starting to provide data for practices using their E&S panel roster for both their Medicare and Medicaid population. And we've also debuted some pharmacy reports as well, because we know obviously managing patients' medication is important to managing their overall health. So started to pull that, which are claims-based pharmacy reports. And then finally, our coaches, as all of you know, have been working closely with practices and CTOs since 2019. And part of what they do is helping practices, making sure they're building the capabilities for advanced primary care and meeting the program requirements and helping practice transition. As we've transitioned, we no longer have track 1. We now have track 2 and track 3 practices are still having to move up into track 2 as well as now into track 3. So a pass rate of 99%. We're proud of that. Next slide. So a few updates here in terms of, you guys know we do an annual report. I think we shared with you, with the council, a draft list of those recommendations. Here's the final list of recommendations we made to CMI that went to CMI in October. And I just want to call out a few things here. So we made policy and operations recommendations for 24 and 25. CMI is working with us now to continue to improve the program operational issues like payments that a lot of practices have had to deal with in terms of recoupments. We're pleased that they've also agreed to adjust their policy timeline to incorporate feedback from this very group. And today we're going to talk about one of the other recommendations we made to them, which is building additional flexibility into the health equity payments, or HEART. Next slide. Okay, so here's an update on where we are in terms of the program size and scope. We have 511 practices participating in MDPCP in 2024. That represents 588 practice sites when you include all of the sites that the FQHCs have. The FQHCs are considered one practice or organization in the program, but have multiple sites as part of their system of care. So program is still significant. It happens to still be the largest state-based Medicare advanced primary care program in the country. And this year, notably, we have one more FQHC. So we now have 13 out of, I believe it's 19 FQHCs in the state. So making quite a good dent in having FQHC as being part of our advanced primary care program and really addressing some of the broader goals that the state and CMS have for having safety net providers as part of these programs. Next slide. Okay, so here I want to note the 25 new starters. We talked about that in the one FQHC, but you can see if you look here in the box on the right, it's a very regionally diverse group that came in 24. So 8 from the capital region, 7 from the central region, 4 from Southern Maryland, and 6 from Western Maryland. So we continue to expand the program, make sure that it really is diverse and statewide. Next slide. Okay, so this is the track breakdown. So as of 2024, we no longer have track 1, hence you see 0 practices in track 1. All practices who are still in the program have moved up into track 2 or track 3. And so interestingly, since track 3 started in 23, which was the first year for it, and then 24 being the second year for track 3, the program is almost at a 50-50 split. We actually have more practices now in track 3 than we have in track 2. So all of you know what we went through to develop and negotiate track 3 with CMMI. It's now here. We have a lot of practices who have met the standards and have made the transition to track 3 as well. Okay, and then just an update on CTO partnership. This should look fairly similar to what you've seen before because the percentage of practices selecting the partner with CTOs really has not changed. It's still 75% of practices are working with CTOs and 25% of them are independent. We've seen a little bit of switching here and there, but overall the numbers are about the same. Next slide. So just in terms of performance, I have listed here through 2022. That's because that's as far as we have in terms of having a full year data to compare 2019, 2021, and 22. We have some 2023 data, but it's only partial year data. That data is in the appendix. But want to call out that the program continues to do what it was designed to do, which is reduce hospital utilization and slow the growth of Medicare costs. So you can see in the top section, reduced avoidable hospital utilization by 28%. And then right below that, it notes that that is 1.25% lower than the equivalent comparison group that we use. Same for the emergency department utilization is also 1.25% lower. And then IP utilization has dropped by 15% since 2019. And that's 5.5% lower than the equivalent group. And on the per beneficiary per month, or the growth in costs, that continues to grow, but at a slower rate than the equivalent population. Next slide. Thanks. Okay, I think this may be the last one for this section. I think many of you have been involved or aware of conversations that the state is having with CMS about potentially going into a new model called AHEAD. So back in the late fall, CMMI released an opportunity for a new state-based model called AHEAD, which is focused on having global budgets, primary care investment, increased primary care investment, and health equity. So a lot of that is what we've already built here in Maryland. So we think the state is a pretty good candidate to continue in this. This is their opportunity, in terms of having state-based models. So what CMS has said is they don't want to do one-off models anymore for each state like they have with Maryland and Vermont. They want a overall program that is state-based, that has multiple states participating in it. So the state has applied for AHEAD. That went in March. And I know some of you were part of the input group in terms of what that application looked like. And if the state is accepted, which we'll find out sometime we expect early this summer, if the state is accepted, this is what the total cost of care model would transition into. So total cost of care model would move into is probably essentially another 10-year model under AHEAD. And MDPCP would be the primary care component in advanced primary care program for the Medicare side that we would like to continue forward. So we see this as the opportunity to keep MDPCP in Maryland in the program. For now, MDPCP is still approved through 26, but it's possible that if Maryland is accepted to AHEAD, we could move into AHEAD as early as January of 2026. And with that, take a break there and see if there's any questions or comments.
I think the internet is down at MHCC, so unfortunately. So let's get it. We'll go on to 4 if people don't have any questions. I'm not seeing any questions right now.
Okay. All right. So I have 3 policy areas I want to talk about today. And this is the first.
So sorry, Carlene has something in here.
Oh, okay.
Carlene, did you have a question? Carlene, you have something. MDPCP will transition to AHEAD. So Chad, do you want to take that?
So that's, Carlene, that is the expectation, but we won't know until we get notice from CMMI, and then honestly, we will, if the state is accepted, then the state will have to negotiate with CMMI what that looks like. But the thinking is that we would continue MDPCP, but probably with some changes to make sure it fits and aligns with what's expected and ahead. But the idea is that MDPCP will continue.
Then Jean had a couple comments.
Well, here, I'll just talk if that's okay. I was trying to do it efficiently, but maybe it's just easier. Are we going to make a list of the things we really want to keep in MDPCP? Because like, I think CTOs, particularly for the small practices, if you look at like what Dr. Akiki's doing in Prince George's County, those 4 practices would not be in if it weren't for her, right? The groups in ours really need our help. So I think that's really important. And then I would also suggest that I would not like it if we went to just a straight track 3 with no onboarding. I mean, there's some things that we need to make sure that we keep. It would be very helpful if this group or the state had some principles. And hypothetically, if there was a push to try to get ahead approved quickly by November, hypothetically, for some reason, just arbitrarily saying, and they don't use the full year, we might have to make decisions quickly. So it just seems this group or some reasonable subset of this group should think about the things that are really important to keep in MDPCP and what's worked, so we don't have a problem where a decision gets made quickly and we haven't communicated clearly to the people that are making the decisions what's important to keep. So I was going to start outlining them from my mind. We're obviously MedChi is working with the Maryland Family Docs to try to come up with a list of the things we really think are important. But that's my concern, just kind of thinking forward of what's going to happen now that we've put our grant application in for ahead.
Yeah, I think those are good points, Gene. I think in the next month or so, there'll be probably some communications about how the state is going to continue to engage with the council, and what that's going to look like in terms of getting feedback and in terms of the design for ahead. So we're still trying to figure out what some of those pieces look like.
Well, I understand that, and we were joking before the meeting started about the 3 different primary care committees and the different way input occurs. My point is, though, is that I do believe that, like all of us on this call, there are certain principles that we're not going to disagree about that we really like about the program. If we could figure out what they are and clearly articulate them, or in some fashion, and give it to the powers that be or that are going to be in the room negotiating, so we don't have a mistake happen, especially if it has to be done quickly. I think that's really important. So I hear what you're saying, and I understand it'll be a process, but I just want to make sure that we don't end up destroying this. This is the largest advanced payment model in primary care per capita in the entire country. It's the most successful primary care program ever. You don't get this kind of engagement in value-based care like we've gotten on this and Equip, if you look at the raw numbers. So we need to make sure that we don't mess up what is actually working. And this program is something that works. So I just think those principles need to be outlined so we don't just get some cookie cutter primary care program that they've used before that has not worked well. That's all. Anyway.
And thank you for that comment, Gene. I think that's something we should take away and consider very carefully and how we can best execute on that.
The only small thing I would add to that, David, is we have a lot of data. So to the extent that Chad's shop already has data to prove the value add, it makes it easier for you to make the case.
Thank you, Dr. Akiki. Chad, back to you.
Okay. Thanks for good comments. Keep them coming. Okay, so this is the first of 3 policy items I want to talk through, and it's a potential performance measure change for 2025. And so we've had several years here, as all of you know, where we have not had any changes, but we're at a point where we have a measure that's not working, and I'll talk through that. And I think many of you in the program know that. But first, the way I've laid out each section here is that the questions that I want to talk about and just have discussion around, or guiding questions, if you will, at the end, I'm also putting them up front, so you can think about these questions as we're kind of going through the section. And CMMI has said they're open to getting more feedback on the measure options. So this is a real opportunity for this group to weigh in on some of the options that we're going to lay out here. We want to hear what you think about these measures, particularly measures that could be aligned to a Medicaid advanced primary care program in the state, and how they would work, and feasibility, et cetera. And then finally, we're not going to have a vote, but certainly want to hear, if there are preferences on measures, particularly if we have to just select one, which measure would that be? So let's keep going here. Okay, so here's the status. We have a measure, and it's an electronic clinical quality measure, pretty standard measure, BMI, measurement and follow-up plan. The problem with the measure that we're finding that started maybe last year is that, but has really sort of picked up in 24, is that some EHRs are not supporting the measure anymore, to the point where not all practices can report it. Part of that's because the measure has been changed and has been removed from the MIPS program. So vendors have stopped supporting it. So I think CMS is at the point where, and we've had to suppress this measure, I think 3 years in a row, where the measure is just not going to work for the entire program to report on anymore. So CMS has said we need to replace the measure for 2025. What they will do for 24, just in the interim, in terms of scoring, is that they're going to do what they call suppressing the measure. And that means practices will get credit for the measure, but they will get just half of it, because essentially they reduce the weight of the measure by half, but they'll get full credit for half of the measure. And then the remaining part of that weight is going to get distributed to all the other measures in the program. So we'll add basically 1% of weight to all the other measures in the program, both clinical quality, utilization, and cost measures. So what I'd like for our group to think about is replacing that measure for 25. What might we want in that? So we have some candidate measures that I'm going to talk through, and then a little bit of background on that. And then let's talk about what makes sense in terms of the measures. So let's go to the next slide. Okay, so these are the measures that we have in the program today. So the top 3 measures that you see here in green, those are our remaining 3 ECQM clinical quality measures. Those measures we're not going to change. Those are pretty standard, and we have had focus on those for several years now. So blood pressure, A1C, diabetes, and depression screening and follow-up. And what you'll see here on the list is what we've noted is there's the MDPCP column, and whether it's in MDPCP, obviously those 3 are in. Whether the Medicaid Advanced Primary Care Program that's being developed for 25 is considering using those same measures, and it is the case for those 3. And then the final column just notes some of the other models around the country and standard places where these measures are used to give you a sense of that. So BMI we have in red, and then the 3 measures that have been proposed potentially for a Medicaid program would be colorectal cancer screening, breast cancer screening, and asthma medication ratio. So the top 2, colorectal and breast cancer, are both ECQM measures, meaning they're clinical measures that are reported out of the EHR. The last one is asthma medication ratio, is a claims-based HEDIS measure.
And Chad, before we move on, I believe Dr. Reedman was going to make a comment here. Dr. Reedman, are you able to speak?
Perfect. I just unmuted myself, David. That was perfect timing. So yeah, I would like to kind of preface this conversation, and actually Jean chimed in with a perfect lead into that just a second ago, with a text there. The issue I have is that, and just for those who are new on the committee, I'm president of Maryland Primary Care Physician. We're the largest independent primary care group. We have like 90 primary care physicians, mostly around Anne Arundel County, Prince George's County, Howard County, and the Eastern Shore. But our size allows us to do a lot of things that smaller groups in the state can't do. And that's always been a concern. And I think the focus of this committee is especially the smaller groups around the state and all. The EPIC system that we use allows us to do a lot of other things, including tracking some of this. But my concern is that with the new proposals, the colorectal and the breast cancer, et cetera, I think that we should be held to measures that we can control. And the problem with, in particular, breast cancer screening is I have a lot of patients out there that I never even see. I don't even know they're my patients necessarily, but they see a GYN as their primary care physician and get their mammogram, and I never get that report. So we've gotten fairly efficient in our group with trying to track that down, but it's a lot of work. Jean made a really important statement a second ago on the text, is that I never could understand why these shouldn't be billing issues. If a patient of mine sees a GYN and gets a mammogram, or sees the GI and gets a colonoscopy, and Medicare pays for it, to me, that measure should be met, versus the fact that I have to track that down and try to find it. I think that's a really good point. So my comment would be that would be an important one for Medicare. to look at, and also the fact that if we're going to be held to a measure, it should be something that we have control over. We certainly have control over blood pressure, A1Cs, and depression screening. And I certainly haven't been a big fan of the BMI because it's just a lot of paperwork. But I think these other measures are fine, but I worry about the smaller groups and how you're really going to track that. So I would preface the conversation with those comments. So I'll turn it over to the rest of the committee.
And Chad, before you move forward and we journey to the questions, there was one additional comment from Dr. Basinski who we don't want to overlook, but he's pointing out the challenges and the relevance of the asthma measure to the Medicare population. So, so noted. Thank you, Dr. Basinski.
Yeah, if we can, David, is it okay if let me run through a couple more slides and then we can really have this follow-up discussion to Dr. Riedman's good points?
Certainly, please proceed.
Okay. So
Chad,
just
that is what you're presenting still related to the measures shared or no?
yes, yep. I'm going to present a little more about the background of the measures as well as definitions, etc.
I'll wait.
So we'll come back to the discussions with Chad.
Yeah. And I'll just quickly go through. I think many of you, know the stats and the relevance of these measures. But if we go to the next slide, this shows you prevalence of these conditions: asthma, colorectal cancer, and breast cancer. On the left shows you for the MDPCP population. On the right shows you a national population, which is obviously a broader all-payer population, and hence you'll see some higher rates. Next slide. And then this slide shows what you see on the left side is asthma. In blue is the national prevalence versus in red is the Maryland prevalence. Now, this is for an all-payer population. So this is what we're getting from surveillance data. So you can see it's similar, but slightly higher, but around 10% for asthma. And then for the national versus Maryland data, we don't have colorectal and breast cancer data. We have the screening data, but you can see screening for colorectal is slightly better in Maryland, as well as mammography on the breast cancer side as well. Next slide. In terms of just cost of this, within the MDPCP population, the attributed beneficiaries, these are per beneficiary per month amounts. And what these represent are not necessarily the specific cost for asthma, colorectal, and breast cancer, but the cost, the beneficiary cost for beneficiaries who have those conditions and may have other conditions. So beneficiaries in MDPCP with those conditions, asthma, you can see is over 1,500, and for colorectal is particularly high, 23, and then for breast cancer is a little less than asthma. So significantly more than what the average is the per beneficiary for MDPCP at 947. Next slide. And of course, when we're thinking about these measures, particularly for AHEAD, and HE in AHEAD stands for health equity, we want to be thoughtful about whether these are measures that can impact health equity. And certainly these measures fit that. Breast cancer, colorectal, all have significant health equity components and disparities that are among them that can potentially be improved if we can improve the quality around these conditions. Next slide. Okay, so last piece, I just want to make sure we all have our level set here. What I want to focus you on in this slide is the definition, so you understand the population that's measured for these particular measures. So for breast cancer screening, it's women ages 50 to 74. Colorectal cancer screening is patients between 45 and 75. And asthma is individuals between 5 and 64. Remember, our quality measures in MDPCP are supposed to be all payer measures. So when practices report, they're not just reporting on their MDPCP population, they are reporting on their entire population. Next slide. Okay, so discussion, these are the same questions we had up before. Dr. Riedman, I think, made some excellent points. I know others probably have responses to that, but I'd like to hear from all of you, your thoughts on these measures, Do you like any of these measures? Do you like all of these measures? If we had to choose one to just replace BMI, which one might that be?
So Chad, please can you go back to that slide that had the measures listed and what you were proposing? And the only comment I have for that is given the fact that the disease burden due to diabetes is 7 billion for the state plus, I think having a preventive measure or intervention to address that, it would be better than just having the HbA1c control when it's already there, it's too late. I'm not a fan for the BMI screening either, but thinking through whether having the full questionnaire to evaluate for prediabetes would be something to get credit for, or adding extra credit for any practice that does implement DPP, something of that sort, because it's a huge gap if we wait for you to be diabetic before we start solving the problem, then preventing it.
Thanks, Dr. Cookie. And I think you may know that the quality measures around prediabetes are really have not been fully endorsed and are really ready for prime time and even supported by the vendors, which is part of the reason we haven't picked up one of those and how we got to BMI. And now we've run into this issue with BMI.
And so Chad, to clarify, you're seeking feedback on below the bar, if you will, below the pink tent bar.
Correct. The three measures in blue or yes.
So
right.
Melanie, there, yeah, if you could do, well, that's fine. So it's the group's thoughts, reactions as it relates to these measures. Dr. Okiki, since you were just speaking, do you have any thoughts specific to the measures here, the last three?
I'm torn between breast cancer and colorectal cancer.
Okay. Dr. Barr, welcome. Good afternoon. Thank you for joining us.
Everybody, not the asthma medication ratio. I don't think it's a good measure. It doesn't really talk about control of asthma, just whether the medication was prescribed. So I'm not a particular fan of that measure. I think the fact that it's not in other programs other than the two you see there speaks to that. Of the other two, colorectal cancer and breast cancer, I think they're across the board used. Colorectal cancer is a long look back period. So that might represent some practical challenges in a practice who is looking for the last colonoscopy several years ago. Breast cancer screening, to Dr. Eatman's point, is a bit more in the control of the practice because you can order and track whether mammography was done appropriately. Not a great measure. None of these are great measures overall, honestly, from a quality measure perspective. But I think either colorectal cancer, breast cancer, I would lean in favor of breast cancer because of the look back periods.
And thank you, Dr. Barr. Dr. Berenson.
Hey, David.
Yes,
David,
sir.
can I just interrupt for a minute and ask Chad a question to clarify? And I just want to make sure that the committee knows that my understanding is that these were suggested by CMMI, but we could also make our own suggestions if everybody has or anybody else has another suggestion that they think would be better. That's true, isn't it, Chad?
That's correct. These are ones that MDH is thinking about considering for the Medicaid program, but we want to align the Medicaid program with MDPCP. So I don't want it to be a free-for-all of any measure you'd like, but if you have a particular measure you think is more appropriate, we're open to hearing that.
So thank you, Dr. Reedman. Dr. Berenson, your thoughts?
Yeah, why did you call me before I raised my hand, just out of curiosity?
Always interested in your thoughts, sir.
Oh, okay, well, could you try to find this, you get these slides went quickly, the ones that show the current performance on a national and a Maryland basis? It's about 2 slides from here. That one. Mammography use among women. I mean, I guess the concern is we might be topping out on the breast cancer if we're up to 88%. If these are comparable to what your recommended measure is, I'm wondering whether there's as much of a gap for breast cancer as for colorectal. I guess I would throw that into the mix.
Very good point. Thank you. Others with, I don't see specific hands, but others wish to make a comment? Perhaps I could invite Dr. Berkowitz to share his thoughts. Okay, we'll come back. I think thought he was there. Oh, Dr. Berkowitz, I see you now. Any thoughts here?
I'd like to reflect on a little bit further, but preliminarily, the colorectal and breast cancer screening ones seem the most appropriate, but I may have further thoughts later. Thank you.
Thank you. Dr. Brzezinski, I saw a hand.
Oh, thank you. I think the colorectal would be one where I think it was a good point that Dr. Berenson made, that there's more opportunity for improvement there. And, subjectively, it's a measure which doesn't quite get the same level of publicity that breast cancer has. And, publicity has driven improved screening rates, as we've seen. So I think there's an, opportunity for colorectal cancer, since it's, something that affects, all Marylanders, all Medicare beneficiaries. And to Jean's point, if there's a way that could be satisfied by, claims data within a look back period, that would be tremendous, because the tracking down of colorectal screening reports can be very challenging. Although I do understand that if the report does come in front of a physician to evaluate, we may catch the fact that it wasn't a clean scope, and you may need a 3-year follow-up scope as opposed to a 10-year follow-up scope. So anyway, those are my thoughts.
Thank you, Dr. Brzezinski. John Lees, your thoughts.
I would just add on to what others have said. From an operational perspective, the more claims-based we can make these metrics, I think the easier it's going to be, and free up time to spend on clinical care and not tracking down reports from another organization.
Right, good point. So, Chad, could you just expand a little more on your thinking? You mentioned the idea here is to try to align with Medicaid, or be in alignment with Medicaid. If the group were to propose an alternate measure, how would that process work?
Good question. I don't know that we have defined how a process would work in terms of pulling together a measure. We have control over what the MDPCP measure is, but we don't want to add a measure that will be in conflict with what Medicaid will do, and vice versa. I would invite Laura Goodman, if she's online, to add to this, but Medicaid is working on a concept that they are putting forward to CMS that needs to get figured out fairly soon in order for them to start in January of 25 in a program with the MCOs under Health Choice. So hence, that's why we're bringing this list to you now. These were the initial measures that were identified as potential measures. But there is, I think, some time right now for us to figure out if one of these is an appropriate measure. I think Medicaid is potentially considering adding all of these measures, but of course, I think some of the feedback they're hearing tonight may help them think about if these are the right set of measures or not. Laura, I hope I didn't speak for you, but yeah.
Thanks, Chad. Thanks, everyone. This conversation is really interesting and really helpful. Let's see, I'll try to take them in order here. I know that for colorectal cancer and breast cancer, those are both identified in the AHEAD model as primary care measures. So, given where the state could be headed and is likely headed, we thought those would be good inclusions for consideration on that front. Of course, colorectal cancer screening, we've been monitoring that in the Medicaid program on a homegrown basis for 7 or 8 years now. And it is a challenging measure, given the look back period, particularly with the Medicaid population, because we have folks, churn on and off. The opportunity to look at that one on an all payer basis, could potentially help with those look back periods. But at this point, we do have Hilltop running it as a kind of year-over-year improvement measure. Of course, that would need to change if it were incorporated here. Obviously, colorectal cancer and there are health disparities with that measure. I think that minority populations, particularly African Americans, have lower rates of screening due to stigma. So the publicity on that, there could be a high level of for improvement there. It is more of a Medicare measure. given the age guidelines. We're kind of hitting the upper age range of our Medicaid folks. But it has become a Medicaid measure in recent years. So there is alignment. Breast cancer screening, obviously, that's been a Medicaid measure long time. You know, for a very long time. It is also included in AHEAD. Asthma, you know, I think Dr. Brzezinski's comments on its importance to Medicaid in the chat is spot on. Dr. Lindsay and I, Dr. Gingy Lindsay, the department's new CMO, we're chatting a little bit about, you know, what does that look like in the Medicare population in Maryland, particularly in our urban areas and among minorities. But the asthma is one that's going to remain a priority for the Medicaid program for sure. So I think at some point going forward, we would probably anticipate whether it's AMR or if there's a more appropriate measure. To the point made earlier, I think we could be open for consideration. I know that Kathleen Loughran from WellPoint is on as well, who has years of experience with Medicaid measures from the MCO perspective. So not sure if she has comments, Kathleen. I'm not putting you on the spot, but wanted to make others aware that she is here for the MCO perspective.
So why don't we invite her to speak, Kathleen?
I'm sorry, Kathleen.
No, you're great. No problem, Laura. Good to see everybody again. So I think I'm leaning a little bit towards colorectal cancer, and the reason why is because it is challenging, and it could be a really good opportunity to educate populations. Now, it does, lean more towards the older set, but there are a number of people who have a need to get it a little bit earlier than typical, and I think you see people at 45, 50, 55. It just may be a good opportunity to try and improve the challenge and stigma around that screening, whether it's Medicaid population or commercial population. There are a lot of educated people who don't appreciate the need for this screening.
Thank you very much, Kathleen. And our executive director has a comment.
Yeah, David, and maybe Dr. Barr would know this, but I thought the U.S. Preventive Services Task Force was going to lower the recommended age for breast cancer screening to 40. It looked like what we were showing was the 50 and above. Those percentages probably would drop down. There would be room for improvement if U.S. Preventive Services Task Force lowers the age for screening to 40. I don't know where that stands, but someone who's more hooked into that work may know.
Thank you, Ben. Dr. Barr, any thoughts there?
There's been looking at the update, looking to see what HEDIS has, if they've updated the measure in HEDIS. Let me get back to 2 seconds here, just looking for it.
Right. And I wonder, while Dr. Barr is looking, getting a different payer's perspective, I think Will Daniels is on the call. Will, are you able to comment here?
David, I don't see him. Oh, sorry, go ahead.
Hi, Melanie. How are you?
Oh, hi.
Yeah, I mean, I think including that measure makes a lot of sense. We would be supportive.
Very good. We can come back, Dr. Barr, if you're ready, if you have a thought.
Yeah, current year still is 50 to 74. I'm looking to see if they announced any updates on the HEDIS measure. And then I'll look at the USPSTF, unless somebody knows, Dr. Reedman, you might know off the top of your head. But, I'll take a look.
No, because it's been changing so much. It's hard to.
Yeah, I know it's in different, and there's different guidance now by different societies. So
exactly,
HEDIS is like what people look in the measures. Again, I'm not saying it's the best measure. It doesn't stratify for risk. It's just kind of general approach. But I'll find if they've changed it, and I'll look at USPSTF, see if they've done anything recently.
Okay, and Dr. Barr, I would propose in the interest of time, or excuse me, Dr. Reedman, that we sort of recap. Perhaps Chad can let everyone know what he's hearing, and we could continue on. I think we have 2 other topics that will take 20 minutes plus, and we're at 10 of the hour. Chad, Dr. Reedman, are your thoughts?
I'm sorry, this is Debbie. I can't find my hand, and I've been in the chat. I just wanted to get my I do believe that USPSTF is lowering to 40. I saw that earlier, so 40 to 50 would be included for cancer screening, and I really do need to advocate for that screening. NIH, I saw a article recently that breast cancer is, nearly twice as many cases of breast cancer in 2023 as colorectal. So I think that that's a consideration, and women's health issues are certainly in need of attention across all populations.
Yeah, thank you. And we're seeing some comments running on by Dr. Brzezinski and Jean Ransom. So your voices have been heard.
Let me,
Dr.
David, I
Reed.
want to make one final comment, just address something that Laura just said a minute ago, about potentially that all three of these measures might be on it. And that may be helpful or not, but I think we need to be cognizant of the fact that every time we add a measure, it's more of an administrative burden to the sites and to the providers. And more administrative burden tends to be less clinical time to spend with the patient. So I think we just need to be cognizant of these measures may be fine, but to add 2 or 3 or 4 more to what we're doing can certainly be an issue for the sites and the providers. So just keep that in mind.
And I think Dr. Brzezinski was echoing your statement, particularly around asthma with prior authorization for some period. So Chad, can you give us a signal of what your takeaway from the discussions that have occurred thus far? And if Dr. Michael Barr has any feedback for us.
I just quick, I dropped in the chat. We don't have to read it, but you can see there's a proposed breast cancer measure for 2025, which does have the lower age range, and it does have both was it screened and was there a follow-up for abnormal. So this for public comment. There's no definitive decision here, but I'll have to let you know the direction that they're going in.
Thank you, Dr. Barr. Chad, your thoughts, what your takeaway is and next steps?
Yeah, thank you. Great discussion. This is what I was hoping we'd get a mix of and get a flavor from the group. One clarification I just want to make regarding Medicaid, and Laura, correct me if I'm wrong here, but Medicaid will probably have a separate set of pediatric measures from the adult measures. So I just want to clarify that. As far as what I'm hearing, I think what we're hearing is there's some preference for it's not. I think what we're hearing is I don't hear anybody loving one specific measure. I heard some people favoring breast cancer screening. I heard some favoring colorectal. Colorectal potentially has more room for improvement. I think before we make a decision on a measure, we probably would do some actual, more data analysis. This is pretty preliminary, obviously, what we're showing here. But we, this has been helpful. I think I've heard less interest maybe in the asthma piece, but asthma is also an important component of Medicaid. So I think that's helpful for them to hear, though, some of the challenges around all of these measures. And I think we'll share some of this feedback with CMMI as well. We don't have to add a measure to MDPCP. I think CMMI would like to replace the measure so that we don't have to change the measure weights in the program. But I think the bigger question for us to figure out with Laura and the Medicaid team is that if they're going to start up an advanced primary care program, that we're in lockstep in terms of what those measures are going to be, because we want the measures for Medicare and the Medicaid programs to be the same and make that administrative burden reduced. So this has been really helpful. I think we'll have to come back. We'll go back and talk with the Medicaid team and the folks at the department about some of the feedback here, as well as CMMI. And then I think we'll follow up with what the next steps are in terms of measure definitions and measure decisions for 2025.
Okay, so Chad, we can, if you would, proceed to tee up the health equity payment flexibility discussion. And I would just note for Dr. Reedman and the members of the group, we'd probably like to hold that to a good 15 minutes on the outside. There's another very important item as it relates to the equip design and the MDPCP transition. We want to be able to save about that same amount of time for discussion. Dr. Reedman, okay to proceed?
Absolutely.
Thank you. Chad, take it away.
Okay, great. Thanks, David. Let's keep going. Melanie, back to agenda item 5. So heart payment, the health equity advancement payment. We have been talking to CMI, you can go to the next slide, about flexibility around using those dollars. So I want you to think about some of the questions here. The goal is to adjust the policy with CMS to provide more flexibility to MDPCP practices and CTOs to use those health equity dollars on Medicare beneficiaries in the MDPCP practice. CMMI is considering changing the policy and making it more flexible for 25 or 26. We're not sure yet, depends on some of their administrative timelines and what they can get through their processes. But we have some preliminary interest from them, I should say more than interest, but we have interest from their leadership on making this happen. We just don't know how fast we can have it. But so the point of bringing it to this group is we want to hear feedback to make sure that we're not off track on what we're pursuing. And that if there are things that we're not thinking about, we want to hear from you to make sure that we can share that with CMMI as they consider this for 25 or 26. So next slide. Okay, so here's the status. We introduced the health equity payment in 22. It provides $110 per beneficiary per month, but remember, it's only for the heart beneficiaries in a particular practice. It's about 6% or so of the beneficiaries in the program, so around 25,000 beneficiaries qualify for these. These are dollars that go to the practice to help address social needs and related care management. It's for beneficiaries who have high HCC scores or medical complexity, as well as high area deprivation index scores based on where they live. While some practices have found some success with really building out their social needs and screening processes and linking to resources and actually building some of those resources sometimes within the confines or connected to the practice, like starting food pantries or providing transportation vouchers or paying for Ubers. Others have been able to spend all of their dollars. So some of the design challenges here are that with heart is that since you have to spend the money on the heart beneficiaries almost exclusively, what practices have complained about for several years now is that those who qualify for heart, while they maybe have some needs, they're not always the right patients who have the most need or have need that can be addressed by the practice. But the restrictions on the Medicare dollars are that they can only spend on those beneficiaries. Number two, because heart eligibility changes every quarter as attribution changes, and the numbers are checked each time for HCC and ADI scores, that continuity of which beneficiaries are on your heart list can change quarter to quarter. Now, CMMI has been very good about starting to build some flexibility, and now they're giving the practices essentially a budget for the year. But the heart beneficiary list still hasn't changed. So what Emily Gruber and our team have been working on for a while now with CMMI is more flexibility. And that flexibility would be what we'll see on the next slide. If you go to the next slide. Great, thanks, Melanie. So the proposed policy change, there's kind of two options, but it's really number one here that we're looking at, and which is the preference, I think, of both CMS and the program management office, which is to enable the practice to use heart on any attributed MDPCP beneficiary. So the second option I'll just lay out here is that it could be a more restricted version of that, which is you could spend it on not all MDPCP beneficiaries, but it would be something that would be an expanded group from what we have today. So potentially something like heart beneficiaries and all dual eligibles or high utilizers. That's kind of our backup option. The real option that we want to explore is doing the first option. We think it will help practices expand their screening and really screen for every beneficiary. If every beneficiary is eligible for heart dollars, it will remove the challenges of those quarterly fluctuations in terms of the list. And we think it's just going to better serve beneficiaries in terms of getting services through the practice. So next slide. So at this point, we're at discussion. Would love to hear people's thoughts on this potential policy change.
And Dr. Reedman, can you kick us off with your thoughts?
No, I like the idea. It's funny. We just had a conversation in my office about we have patients that have needs. And in the past, we've we have gone out on our own and helped those patients. And it might be anything from a Uber ride to the office or Uber ride home or anything on those lines. It'd be really nice to have these funds available for all our patients, because you're absolutely right. We have some heart patients that really don't have any needs, but we have to spend the money on them. And that's been a challenge for us. So I agree with the idea and the proposal that we would expand this to pretty much all of our MDPCP patients.
Okay. Thank you, Dr. Reedman. Others, how about if I invite John Lees to make a comment?
Sure, I think it would be a great idea, Chad. As others have pointed out, we struggle a lot with patients who don't qualify for heart but definitely have a need. And it would be so much easier administratively. And again, we use a lot of time, trying to use those funds some months and come up with challenging ways to use those funds specifically for heart patients. If we could expand that to, go beyond the heart patients, I would even say come up with, some type of guidelines, high HCC scores or high acuity scores, patients with XYZ. I think that would really operationally be, very palatable to certainly my practice and the other practices as well.
Thank you, John. Dr. Brzezinski, from your views from Western Maryland.
Oh, great. Thanks for calling on me. Yeah, I mean, we're in a resource limited area and we don't have a lot of resources to spend the heart money on. Like there's no Ubers for us to use or things like that. That was a great idea. I heard some of the practices using. But I think that opening it up to all MDPCP, the money could be spent on all MDPCP beneficiaries, then that would catalyze a culture shift in small practices to start, globally looking at SDOH type of stuff. Because, if it's like, well, we've got these couple of patients we could use this, money on, and, which one is it? We have someone trying to ferret that out. But if we say, hey, anybody MDPCP, basically anybody Medicare, we can use this money on them. And then that would create, just like we want to have more standardized quality metrics for clinical care. I think if we have more standardized, consistent processes across the board for addressing SDOH, I think that would be good use of this money, not just to benefit the beneficiaries, but also to catalyze, behavior and cultural change within practices and within providers.
Wonderful. Thank you, Dr. Brzezinski. Ben, then Dr. Trumbull, then Dr. Berkowitz.
Yeah, I just wanted to be clear about, this strikes me as abandoning the ahead methodology. I think people have made some good points, but the ADI doesn't change quarterly. It's the HCC scores that are changing frequently, or the attribution rules. Is that correct, Chad?
That's correct on the attribution. We adjust every quarter the look back period. ADI, I think you're right, Emily. Is that right? It doesn't change quarterly?
Yeah, that's correct. Sometimes quarterly the ADI cutoff changes based on the beneficiary population. So that could change, but for the most part, it's HCC score changes.
I know we have a little bit of time here, but I think we have to think carefully about this. There would be questions about what a practice's ahead budget would be if it's open to all patients, and this is the assessment of the practice. I think from the standpoint of program integrity, from someplace like the OIG, that there would be controls that would need to be substituted if we're not using the ahead methodology. But I appreciate the concerns that have been raised.
Yeah, that's a great point. Thanks, Ben. Dr. Trumbull?
So I'll just add in real quick. One of the feedback that I've gotten from some of our practices is that while this current approach with a high HCC and high ADI really potentially impacts the highest risk individuals, rising risk individuals are an area that we have a great deal of difficulty really intervening at a point where we actually could do something before their disease process progresses to a point where now we're thinking of it in terms of how many readmissions are we going to have. So I think expanding the program in some fashion, but I do agree with Ben. There's probably going to be some limitation that we're going to have to put on there. But I was thinking along the same lines. I thought ADIs actually changed on a yearly basis, which seems like that would be a way to kind of curb the idea that, because we don't want it to be abused either, and I'd certainly see the OIG getting involved if we started down that path. That's it. Thanks.
Thank you, Dr. Trumbull. And then Dr. Berkowitz.
I was just going to support the PMO's recommendation. I think that having some additional flexibility related to that would be helpful in terms of identifying the patients that may be most likely to benefit, and also to allow some of that flexibility related to sort of churn or changes, so that it isn't as administratively cumbersome in terms of managing.
Dr. Berkowitz. And Debbie, it might be good if you sort of summarize your thoughts.
Yeah, I wrote it in the chat. I fully supportive of this. It's really hard to provide needed services and then because somebody might fall off the next quarter to stop them. I think the larger group or expanded eligibility would help with that. And I think the care managers and the physicians know who really is in need of services. And I would think that there would be some, as long as there's documentation of the need, that there could be some other way to give the, regulators comfort that it's being used appropriately.
Okay, and can we get a Medicaid perspective out of curiosity? Laura or Kathleen, could you just share your thoughts here?
Sure. So, just hearing about this for the first time, but Debbie, I was thinking something along the same lines that, monitoring, completely hear that use case of having to say, well, you didn't make the list this quarter, so you no longer get transportation support or, whatever else Heart is helping out with. I think that monitoring, I know HSCRC, for example, uses a methodology that uses ADI, race and Medicaid status to track, to kind of apply to their measures as a secondary filter, I guess. Maybe I'm not Allison Schuster or Jeff Doherty, so I can't really say it properly, but perhaps something like that could be applied to the Heart payments that are going out to kind of see, by race, maybe dual status as a measure of income, and just kind of making support. Because my understanding was because MDPCP historically has served better off areas, this was CMMI's approach to try to direct monies towards those who might need additional support.
Thank you, Laura. And Dr. Okiki.
Yeah, I do agree to allow for more flexibility and even maybe go slightly beyond, because for some practices, this amount of money is really, really small. So just to have some meaningful impact, to see how they could use other monies, PBIP. I know some practices were already using some of that for heart-like payment type support for patients. So just keeping that in mind. In terms of Medicaid, the Medicaid population have more SDOH concerns compared to the Medicare beneficiaries just in general. So something to think about, that this is something that will be considered for that cohort of members, patients, or beneficiaries, that it might require more than just what is being provided now under NDPCP.
Thank you, Dr. Okiki. I would ask Dr. Riedman, are you okay if we summarize here and move on to the last agenda item to give it sufficient time?
Yep.
Chad, when you proceed to summarize what you're hearing, could you also remind the group, the question came up about the budget, meaning that the budget could actually change every quarter. This would not prevent the flexibility or the changing, correct? But it would affect how the practice could apply the funds. Is that correct? Or is there that need to be clarified?
I'm going to go to call a friend who could better explain this. So Emily, do you mind doing a little explanation on that?
Sure, happy to jump in.
Thanks.
Yeah, so as of this year, 2024, the budget for heart for each practice remains constant each quarter. So that would be maintained in the future as well. The budget wouldn't change. We would just include additional flexibilities as to which beneficiaries practices could spend heart funds on.
And it would be established annually, correct?
Yes, exactly. The budget is established in Q1 of each year.
I think that answers the question. So Chad, please tell us what you think you're hearing from the group.
I think I heard pretty broadly that the group likes the idea of broader flexibilities. And it seemed like most of the group thought that the fullest flexibility that we can get would be the best, which would be to allow heart funds, so the calculation for heart fund wouldn't change, but which beneficiaries it could be used on. So it could be used on all attributed beneficiaries would be the preference of the group for MDPCP practices and the CTOs who both get this money. I think there are some good questions about how does this get monitored and making sure that we're careful about where things are spent. I think CMS, as you know, is pretty good about putting in restrictions and legal language that this would be subject to. And certainly this will have to go through a variety of approvals through the legal counsel at CMS. So I think we'll have a lot of vetting of it if we're able to get it in 25 or 26.
Outstanding. Wonderful. Thank you all for that conversation. So continuing onward, our last topic of policy discussion relates to agenda item 6, which is the EQIP design for primary care as the MDPCP transition. And I believe Jean is going to also contribute here to the facilitation of this segment. Chad, please proceed.
Yeah, thanks, David. So same setup here. Here's some questions to consider. I'm going to just briefly describe this proposed program and some of our questions, which are here. And then I'm going to ask Jean from MedChi, who's the EQIP chair and leading the work on the EQIP PC design, primary care. But also Krista from HSCRC, Krista Spiker, she's developing the state's proposal in conjunction with Jean and the subgroup on this. And I'm going to ask them to add some color commentary and some details after I finish. And then we can talk about how this fits and what with MDPCP and what transition might look like and some of those related questions. So next slide. Okay, so a quick little background here. EQIP is a program that HSCRC runs with CMMI approval to provide value-based payment opportunities, particularly for specialists around the state. So EQIP PC is being considered as essentially an offshoot to address primary care needs in underserved areas of the state, to develop new primary care practices, new primary care access in underserved areas of the state. EQIP comes with a fair amount of authorities to allow the state to run the program, and hence that's why there's consideration of using it to develop this primary care access program that would complement MDPCP. The program is being developed for consideration by CMMI now, and if it gets approval later this spring, the idea would be to start it in January of 2025. HSCRC put out an RFI to get feedback on this. I know some of you have been involved in that, as well as the subgroup that's thinking through the issues of the program. The program would come with some payments, so it would come with some upfront infrastructure funding. It would come with some per beneficiary per month monies for the Medicare beneficiaries in the practice for potentially 3 to 5 years. And then the third potential payment bucket is a shared savings opportunity in years 4 and 5. There are some potentials. I think these details are still to be worked out with CMMI, but potential opportunities for AAPM status and potentially even some primary care bundles. And HSCRC is thinking about for this program that a transition to MDPCP may be part of the requirement if you want to continue to receive per beneficiary per month payments from a Maryland model program. So next slide. So just a couple notes here, and then we'll go to Jean and Krista. There are some elements in it that I think have purposely been built to look like MDPCP. In some ways, you can think of this as almost like a track one for areas that don't have advanced primary care, and particularly for areas that don't have much primary care at all. And so some of those are in the model of care. There are requirements around developing care management capabilities, having integrated care such as specialty coordination, and doing community linkages so that, you know, addressing social needs, the health equity component of primary care as well. The quality measures, the thinking is that those measures would be aligned with MDPCP. So going back to our earlier discussion about a Medicaid MDPCP alignment, the thinking is that EQIP PC would also align to the same or a similar set of measures. The one thing that's similar and different is that there is attribution for this program that would probably be built. My understanding is around either plurality or a particular code like an AWV, but there won't be a minimum. So that will allow us to bring in practices that may not be able to meet, you know, 125 minimum that we have in MDPCP. So let's go to next slide. So I think we're here at discussion, and Jean and Krista, anything you want to add to what I said?
I don't have anything to add. I mean, there are some more details, and we have a website. I can put that in chat for folks that want to see the slides from the last subgroup meeting, but I don't have anything else to add to what you said, Chad. Thank you.
I was just going to say I just want to point out that one of the things we really want to do is focus on creating new primary care that can then, after working through the program, create new capacity in critical areas and move into MDPCP. And the goal is not to have overlap, but to coordinate. And that's really what we've been trying to do. And I did just want to put a thank you out to Krista and John Crum and everybody at the HSCRC who's been working on it, because I really feel like this is, I mean, we're trying to do it obviously very quickly. The money became available in December. And I think this is just a great opportunity because we have incredible shortages of primary care. I think one of the other things is we want to make sure that the money goes to new primary care and it isn't supplanted or it really ends up creating new capacity. And that's really the goal of the program. The other thing I wanted to mention is that if we can keep a introductory track in MDPCP, the other thing we can do with EQIP is have some bundles which might allow primary care doctors to take advantage of advanced payment models. I won't spend a lot of time talking to that. If you watch the video of the last EQIP meeting, the sub meeting for primary care, which is on the MedChi website and will eventually be on the CRISP website, you can get that discussion, but that's another benefit of the program. And that's another way we're kind of trying to supplement MDPCP and help docs kind of move into value-based payment.
Thanks, Jean. Thanks, Krista. So let's, Dr. Riemann, David, let's open it up for discussion. Certainly, I think Jean and Krista are happy to take questions if people want more details now, but I think in particular, I want to hear about how do you see this working with MDPCP? Do you see practices being ready to transition? How long do you think that would really be when we're talking about essentially new primary care in underserved areas? Should practices be required to transition to MDPCP? And what other challenges might we see along the way?
So could I start the conversation by?
Yes. Did you freeze, David?
I think he's frozen.
You froze. Well, while we're waiting for David to unfreeze, Jean, is there a map or a list of what those underserved areas are that we can look at?
The proposed list is in the deck that Krista put in the chat.
Okay.
It's actually in the deck.
Mm-hmm.
Go ahead, Krista.
Yeah, so I just want to say that's sort of a draft of a map. We're finalizing that in the next couple of days, Dr. Riedman, and hope to send that out to the subgroup where we have the list of zip codes, all of the detailed information so that interested organizations can know if they're eligible. So yes, that will be sent out, and that will be in the next, we'll discuss that in more depth in the next subgroup meeting in April.
So, Dr.
And we can send the link to the next subgroup meeting. Those are open and recorded. So we can send that to the entire council if anybody wants to come. I know Dr. Bazinski and a few others on the call do come to those.
And I will say that if you take a look at the map in this slides, what we're finalizing is very similar to that. And I think it's in the areas of the state that we would expect, or that you would expect. There's Western Maryland, there's PG County, there's the Eastern Shore, Baltimore City. So just wanted to kind of clarify that that's the draft map the final map will be similar.
And just there's two questions in the chat really quickly. So Chad said HIPSAs in particular. It's actually more expansive in HIPSAs. It's a little closer to the zones the HEZs had a few years ago, for those of us who are old like me and remember that. And then Dr. Barr, the FQHCs, I believe our plan is to have them eligible. Actually, our hope, and we had a lot of discussion at the last meeting about this, is that we would want everybody to be able to apply, FQHCs, hospitals, small private practices. So it's really, we want to make it it's going to be a competitive process, and that's where we are.
So thank you, Gene. Can we invite Debbie and then Dr. Berenson and then Dr. Brzezinski?
Yeah, I think the intent of the program to get primary care in underserved areas is excellent. I finally realized that this is more in that slide that was presented. It is more MDPCP like than it is EQIP bundle like. But then, Gene, you talked about the bundles coming into it, so I'm starting to figure that out a little bit better. I do think that there needs to be a transition, though, and if we could keep a track one. My concern would be with the head and MDPCP and then this. We don't want, so many different kind of models that we're going to then have unintended negative consequences of other models. So I would hope that a lot of the metrics would end up being the same, and that it's kind of like seed to get these practices established, but then there would be the same kind of progression, moving forward. Otherwise, I'm afraid, it's kind of a two-tiered kind of thing, and I don't think that that's good for the state.
Thank you.
I don't know if Krista wants to say anything on that, but we're a lot of discussion about that issue at the last meeting. And I think the thought process we're thinking is that you would not be able to collect both MDPCP funds and the EQIP primary care special program funds. And the idea would be that we would essentially transition people in 3 to 5 years. And I think, Krista, right now you have it at 5 years. There's a total cutoff for this one. And the goal is to get everybody into MDPCP. And the secretary has also said quite clearly to all of us that the goal is to have this kind of create a feeder and augment MDPCP and bring people into it, not supplant it or create confusion.
And as Chad is saying that, and then all of us moving together into a head.
Yeah.
Well, the MDPCP is part of a head, right? I'm hoping it's going to be. So, and the other point on the bundles are separate, right? So the bundles, a primary care doctor could theoretically do one of the bundles if they had enough today. And if anybody's interested in that discussion, and if anybody has practices in track 2, they should do EQIP. It's a no-brainer because you get the AAPM bonus, and you can do a call with me offline. That's a longer conversation, but I can explain why it's economically beneficial and good for patients. Dr. Berkowitz, I think, did you have a question? No?
Well, I was just I really like the way you frame that, Gene, and thinking about as sort of a ramp into MDPCP. So it actually is connectivity, and whether it's sort of pre-MDPCP or a track of sorts. And it may be hard to say the exact number of years. The premise of this, of making sure that there's more support in underserved areas, makes good sense. But one can imagine that practices may have different timelines to getting to that level of readiness. As long as that ramp is connected to the MDPCP program itself, it may make sense to allow a little bit of flexibility in terms of what that specific timeline might look like.
Yeah, the funding that we have is for 5 years, but certainly I think if there's, opportunity to expand that, we want to provide the infrastructure funding right now is really set for 2 years, but we want to we think we'll be able to make that available for 5 years so that practices can get that infrastructure funding as much as they need up until the transition to MDPCP. So really want that infrastructure funding to be available to practices as long as they can get it and as long as we have it available.
I just want to say one more time too, I've been amazed at how great a job the HSCRC staff has done on this. I mean, literally, I think it was it the November, December meeting they voted to create the funds and told us to do this. And here we are, we're probably going to have an application in the CMMI in a month. So the very fact that we're moving this quickly is incredible. So I would suggest that it's really important, if anybody has concerns or issues, tell us, because when you move fast, sometimes you might make a mistake. We're trying not to, and we're trying to talk to everybody, and we're trying to be super transparent. But I just applaud the work they've done, and really we are asking for as much input as possible.
I think David might be frozen, but I think Ken has his hand raised.
Yeah, thanks.
Sure.
I just want to say,
Hi.
I really, was impressed with the methodology for finding the target areas. That was a really neat combination of, primary care practices, ADI, HIPSA. I thought that was a tremendous way to target the, focus areas on this. I think this conversation actually is a little bit more crystalline than some of what I heard on the actual equip meeting, because it felt a little disparate between, we're looking for practices with track record, local connections, describing the characteristics of existing practices. But then at the same point, it seems like the conversation here today seems very crystal clear that we're trying to get new practices, not existing, which are new entities, to try to get into this. And so it sounds like if existing MDPCP practices would not be eligible for this. Am I reading that right, Jean and Krista?
No, sorry, Ken. And I think you sent a great email, and I'm sorry I haven't responded to that. And you kind of raised this issue. I think
Right.
I think what we're trying to get at, and maybe I can just explain this a little bit, is that if there's an existing practice in the area that is can add practitioners, certainly an MDPCP practice can add practitioners, and we would welcome that. We want to make sure that it's new access. I mean, that's and as Jean said earlier. So I don't it is about however we add new access. I think that's the goal. If it is a whole new practice, great. If it is an existing practice that has a lot of experience and knows the population, the community, I think, we're open to that as well. And maybe the scoring needs to be adjusted a little bit to reflect that, so that we're not maybe weighting those as equal. I think, but I hear that concern, and certainly don't want to confuse folks. I think it can be both or either, right? So does that?
Right. So Dr. Bazinski, if out in Garrett County you decided, we want to make it so you guys, who are very active and doing a great job at MDPCP, if you wanted to add a practitioner using the MDP Equip program, that you could apply for that competitively and show that you're adding new capacity. The problem is we want to make sure that what you don't do is just take one of the existing practitioners, pull them out of MDPCP and apply for it, and kind of game the system. And I know you would never do that. And I'm sure that none of the hospitals would ever do that or anything. But, we just need to, if men were angels type thing, right? We're trying to figure out how do we only spend this limited resources on new capacity and additional capacity. And that's why we had the long discussion at the meeting about NPIs and TINs and things like that. So we're trying to figure that out. So that's where we're having trouble, is the detail on how do we figure out what is new capacity. I don't think we want to limit new capacity, whether it be in an existing practice, as long as it's really new. Does that make sense?
That does make sense. It seems like a dichotomous goal, though, where, it's, I don't know. Be interested to see how you guys ferret that out and come to resolution with it. Because right now, as a consumer of this potential Equip program, it sounds like, well, which one is it? And especially discussion around a new TIN number for anybody who applies. I mean, that's a new TIN number, is like, that's a new entity. That's not a existing entity. So
we're trying to figure that out. That's complicated, right? And maybe it's a bifurcated test, but we can that's something that's not figured out. But look, if Dr. Reidman in Maryland Primary Care says we're not in Dorchester County right now, Dorchester County is a large swath that would be eligible. They have a site in Queenstown. If they create a new site in Dorchester using this program to subsidize it, well, that's great, right? And that and they're in MDPCP and they're in Track 3 and doing a great job. If you guys decided I want to move out to, I guess you're in Oakland right now, I don't know, wherever, Cumberland or wherever, and have a new WellSpan office or whatever, so I think the point is we want to have that as a potential opportunity. We're just trying to figure out how do we do it in a way where we don't have somebody cheat,
Right. Of course. Yeah. We really want to, get new access, additional access, not just, retooled existing access.
And then we get them to MDPCP in 3 to 5 years so that they're part of the system and we can fund a new access because we have an incredible shortage. Anyway.
I think that part of your vision is very clear and crystalline, and it really makes a lot of sense. You'll use this as start a practice, move them towards MDPCP. MDPCP saved my practice when it came into existence, and it's a way that provides sustainable primary care services. So, I mean, this is the way of the future. This is the way we're going to maintain what we have, and I'm all on board with getting new primary care through EQIP and any other means in this state, because I think that's where you really shift the needle on improving people's lives, health outcomes, and getting better value. So, thank you.
Thanks everyone. We're at 5:30, I mean 6:30, sorry. And in the interest of everybody's time, I think these conversations are great. I think David may be frozen. If not, you can chime in. Otherwise,
I'm back.
Okay, I'll let you go ahead and take it then, David.
Thank you, sir. And I think we echo, the MHCC team echoes Dr. Reedman's point. I would like to invite our executive director to share any closing thoughts he has before we talk next steps. He may still be froze.
No, I don't have any, in recognition of the spotty internet connectability, I'm going to reserve my comments for a future meeting. It's been a struggle here, but it's always a struggle when it rains. It seems like so. The deities that are attending, please have the MDPCP meetings on sunny days because it matters. Thank you all for attending.
Thank you, Ben. And so Melanie, do you want to take us to closing?
Yeah, great. Thanks, David. This was a really great conversation tonight. I think that, very, very productive meeting of the council. So again, thanks everyone for their insights and feedback. So those EQIP subgroup meeting slides and recording were posted with the meeting materials for today's meeting, also on the MDPCP page for people who are interested. That's where we'll also be posting the meeting summary and the recording for this meeting. We don't have a next meeting scheduled at this time, but you'll be hearing from us well in advance of a next meeting. So turn it to David just to close us out and say goodbye to everyone.
All right, everyone. Enjoy your evening and drive safely if you're still out having a commute, and we look forward to talking to you soon. Be well.
Good night.
Thanks, everybody.
Good night.